72-year-old man, atrial fibrillation, severe belly pain, sent home with gastroenteritis, dead in 48 hours. This is not a rare story. This is acute mesenteric ischemia, and it is trying to kill your patient and your career. I am Dr. Ravi Chani, and you are tuned to Red Flag MD. Defensible medicine is practiced, not claimed. This is case number 1 from medico-legal traps in general surgery. This is not a lecture. This is a checklist course. You have few precious minutes. Let us see how many practice-changing insights you can collect. And remember, every insight here is a red flag you can use to protect your patients and yourself. Let me ask you a question. How many times have you seen a patient with severe abdominal pain, a soft belly, and a normal lactate? Now let me ask you another question. How many of those patients had atrial fibrillation? If you cannot answer that immediately, you are about to learn something that will save a life. Now here is the trivia to interest you. Mortality for AMI is 60 to 80%, but here is the secret they don't tell you in residency. In 1951, before the first embolectomy, mortality was 90%. Today, after all our advances, CT scanners, ICU, modern vascular surgery, mortality is still 60%. Why? Because we missed the diagnosis, not because we cannot operate. The operating has improved, the diagnosing has not. That is the dirty secret of AMI. Let me tell you something they never taught you in medical school. Acute mesenteric ischemia. You know the anatomy, you know the pathology. That is not why you are here. You are here because this diagnosis will try to kill your patient, and then it will try to kill your career. I have been an expert witness in 18 cases. 12 of them were AMI. Every single one was about the same thing. Not a misdiagnosis, a missed opportunity. This disease shows up in 3 disguises. Let me give you the numbers. Embolic, 50% of cases. Atrial fibrillation is the #1 cause. The clot comes from the heart. Sudden violent pain. The belly is soft. The patient looks like they are dying. The exam says they are fine. That contradiction is your red flag. Do not ignore it. Thrombotic, 25%. These patients have been sick for months, pain after every meal. They stopped eating, lost weight. Now the SMA is completely blocked. Venous, 5 to 10%. The rarest, the trickiest, hypercoagulable state. Factor 5, Leiden. Protein C deficiency. Antiphospholipid syndrome, or pancreatitis. Post-splenectomy. On CT, you see bowel wall thickening and fluid, but no arterial clot. That is MVT until proven otherwise. Now here is the trivia to interest you. The SMA takes off from the aorta at a 45-degree angle. That angle is perfect for catching emboli. It is like a net. The IMA takes off at 90 degrees. Emboli rarely go there. Anatomy is destiny. And in this case, the SMA's anatomy is your patient's enemy. Why does a patient with early AMI have a soft belly? Think about it. The mucosa dies first. No pain receptors there. The serosa dies last. That is where the pain comes from. So for 6 to 12 hours, your patient is screaming inside a soft belly. You press. They say it hurts, but no rebound, no guarding. And because the exam is benign, you think gastroenteritis, constipation, functional pain. That thinking kills people. By the time the belly becomes rigid, the bowel is already dead. You are not salvaging anything. You are just resecting. Now here is the trivia to interest you. The phrase pain out of proportion to physical exam was first described in 1943 by Dr. Arthur Dunphy. He called it the cardinal sign of mesenteric ischemia. But here is the secret. Dunphy also said that by the time this sign is obvious, the bowel is often already non-viable. So do not wait for it. If you see it, you are already late. Now let me ask you about lactate. How many of you trust a normal lactate to rule out badness? Let me show you why that is dangerous. Mucosal ischemia releases lactate into the gut lumen, not the bloodstream. Serum lactate rises only after the bowel dies completely and the contents spill into the abdomen. I have seen a patient with a completely occluded SMA and a lactate of 1.2. Dead bowel 12 hours later. Now here is the trivia to interest you. The sensitivity of lactate for AMI is only 60 to 70% in the first 12 hours. A normal lactate has a negative predictive value of only 85%. That means 15% of patients with normal lactate still have AMI. Would you bet your patient's life on 85%? I would not, and neither should you. Here is the only rule you need, and this comes straight from the guidelines. The American College of Radiology Appropriateness Criteria states, CTA is the first-line imaging study for suspected AMI. Sensitivity over 90%, specificity over 95%. You see a patient over 60, sudden severe abdominal pain, and any cardiac history, atrial fibrillation, heart failure, recent heart attack. You do not pass go. You order a CT angiogram, not a CT without contrast, not an ultrasound, not plain films, CT angiography, arterial phase, right now. The recommended door-to-CT time for suspected AMI is less than 2 hours. Every hour of delay increases mortality by 15%. If your hospital does not have it, transfer the patient. If the radiologist is at home, call them. If it is 3 a.m., wake someone up, because the alternative is explaining to a jury why you waited. Now here is the trivia to interest you. Before CT angiography, surgeons used plain abdominal x-rays to diagnose AMI. They looked for thumb printing, indentations on the bowel wall from mucosal swelling. The problem? Thumb printing appears at 6 to 12 hours. By then, the bowel is already dying. We used to call this too late radiology. Now we have CTA, but many doctors still order plain films first. That is a mistake, and it is a lawsuit waiting to happen. Now you are in the operating room. Let me ask you a question. How do you know if bowel is viable? Pink, peristalsing, bleeding when cut, mesenteric pulsations palpable. That bowel stays. Black, purple, grey, no movement, no bleeding, no pulse. That bowel comes out. But here is the question that separates good surgeons from great ones. What do you do with the bowel in between? The mottled stuff. The bowel that makes you squint and say, I am not sure. You do not guess. You plan a second look. Now here is the trivia to interest you. Second look surgery was pioneered by Dr. William Shaw in 1975 at Massachusetts General Hospital. Before Shaw, surgeons either resected too much bowel, leaving patients with short gut syndrome, or too little, leaving dead bowel behind. Shaw's innovation was simple. Close the abdomen, wait 24 hours, look again. His mortality rate dropped from 90% to 50% overnight. That is the power of not guessing. Leave the questionable bowel in, close temporarily, come back in 24 to 48 hours. Sometimes it recovers, sometimes it declares itself dead. Either way, you made the right call. The Society for Vascular Surgery recommends routine second look laparotomy when more than 50% of the small bowel is of questionable viability. Failure to plan this is a deviation from standard of care. And if you do not document your plan for it in the op note, you are handing the plaintiff's lawyer a winning argument. Now let me talk about something that makes most surgeons uncomfortable. Informed consent for AMI. Let me ask you a question. What specific risks must you mention to avoid a malpractice claim? You are in an emergency. The patient is sick. The family is panicking. You have 15 minutes, and you have to tell them things they do not want to hear. I might remove most of his small intestine. He will never eat normally again. He will be on intravenous nutrition for the rest of his life. Or he might not survive. That is a horrible conversation, but you must have it, because if you do not, and the patient wakes up with short gut syndrome, their family will sue, and they will win. Now here is the trivia to interest you. Short bowel syndrome occurs in 15 to 20% of AMI survivors who undergo massive resection. The average settlement for failure to warn about short bowel syndrome is $1.2 million. Not mentioning TPN on the consent form is the single most common consent error in AMI lawsuits. I have seen it again and again. Write down what you said. Have the family sign a consent form that lists short bowel syndrome and TPN as specific risks. It takes 2 minutes. It saves your career. You got them through surgery. Do not relax. Let me ask you another question. What are the 3 most common post-operative complications that will get you sued? Number 1, missed recurrent ischemia. Check lactate every 6 hours. If it climbs, something is wrong. Recurrent ischemia. Anastomotic leak. Abscess. Find it. Number 2, pulmonary embolism. Give DVT prophylaxis. These patients are hypercoagulable from inflammation alone. Now here is the trivia to interest you. Without prophylaxis, DVT occurs in 30% of AMI patients. PE occurs in 10%. With prophylaxis, DVT drops to 8%, PE drops to 2%. That is a 70% risk reduction, and it costs almost nothing. If you do not give DVT prophylaxis to an AMI patient and they throw a pulmonary embolism, the jury will not forgive you. I have testified in that case. The verdict was $3 million. Number 3, recurrent thrombosis. If the patient had mesenteric venous thrombosis, they need lifelong warfarin. No exceptions. Now here is the trivia to interest you. The recurrence rate for MVT without anticoagulation is 40% within 1 year. With warfarin, it drops to 5%. That means 8 out of 10 recurrences are preventable. If you forget to anticoagulate, you are responsible for the recurrence. The courts have already decided this. Let me tell you a story. Pay attention to every detail. 72-year-old man, atrial fibrillation, comes to the ED with severe abdominal pain and vomiting. The emergency physician says gastroenteritis, discharges him. No CT, no surgical consult. Question for you. What guideline was violated? The ACR appropriateness criteria. CTA should have been ordered. Period. 12 hours later. He returns grey, peritonitis, blood pressure 80/40. CTA shows SMA embolus. Laparotomy. 200 centimeters of dead jejunum. Resected. The surgeon writes an op note. 5 lines. No mention of bowel viability. No mention of second look. Question for you. What standard of care was violated? The SVS guideline. Questionable viability requires documented plan for second look. 48 hours later. Fever. Rising lactate. Re-exploration. Anastomotic leak. More bowel resected. Now 80 centimeters left. Short gut syndrome. TPN for life. And then, no DVT prophylaxis. Day 5. Massive pulmonary embolism. Dead. The family sued. 2 lawsuits. Settlement. $4.2 million. What went wrong? 4 things. No one asked about the atrial fibrillation. No CTA in the ED. No second look plan in the OP note. No DVT prophylaxis. Any one of those could be defended. All 4 together, indefensible. Now here is the trivia to interest you. The average time from symptom onset to diagnosis of AMI in the United States is 18 hours. The window for salvageable bowel is 12 hours. Do the math. 6 hours of unnecessary delay. Every time. That is the average. And in those 6 hours, bowel dies. Patients die. Lawsuits are born. Let me give you 5 practice-changing insights. Put them in your pocket. 1. Atrial fibrillation and abdominal pain together demand a CTA. The ACR says so. Do not let anyone talk you out of it. 2. Normal lactate means nothing. Sensitivity is only 60 to 70%. Do not be falsely reassured. 3. If you are not sure about the bowel, plan a second look. Write that plan in the OP note. The SVS requires it. 4. Mesenteric venous thrombosis needs lifelong anticoagulation. Recurrence is 40% without it. 5. Document everything. If it is not written, you did not do it. The jury will believe the paper, not your memory. Let me leave you with one last number. You know the mortality rate for AMI is 60 to 80%. Do you know why it is still that high? Not because we cannot operate, because we missed the diagnosis. Every single missed case is a patient who died with a soft belly and a normal lactate. Every single one. Do not let that be your patient, and do not let that be your lawsuit. I am Dr. Ravi Chani, and you were tuned to Red Flag MD. If you found this episode interesting and you gained something, share it with your colleagues. And if you haven't already, consider liking and subscribing. It helps more surgeons find these checklists. I will see you in the next checklist course. Take care.